either diagnose a heart attack and then someone else kind of takes care of the interventions, like heart stents, for example. Mostly I get involved in the care thereafter, after the acute phase is over. I'm kind of instrumental in kind of going forward. Heart failure, which is basically a heart muscle issue where people can fill up with fluid. Heart valve issues, which include valves that are leaky or valves that have an issue with opening or closing. Heart rhythm issues, which is arrhythmias. High blood pressure, which is probably the bulk of what my patients have. Blood vessel plaque buildup, which is related to heart attacks, but also other diseases. And then I can do pacemaker and defibrillator checks. I don't put them in. I'm not a surgeon or a proceduralist. Some of my partners do implant pacemakers, however. So just a broad definition for heart disease or cardiac disease, I use those terms interchangeably, and encompasses several different disease processes. The majority of adults over 60 have one of them. So it's a very common affliction. Slides are starting to get a little outdated, although they do them like once a decade about kind of estimations and patient population studies. But in about almost 10 years ago, it was 17 million deaths. It's probably closer to 20 at this point. It's the #1 leading cause of death for both men and women, so both genders in the United States and most of the world. You know, the way that I kind of describe heart disease to a lot of my patients, you know, the heart is best thought of, in my humble opinion, is sort of like a house. So I kind of parse it out into plumbing, electrical, and doorway and structural issues. So kind of 3 broad categories. So plumbing issues would be artery issues like plaque buildup, which could lead to heart attacks. Electrical issues, and that includes things like heart arrhythmias, such as atrial fibrillation, the most common arrhythmia in America and across the world, and then ventricular arrhythmias, which are the life-threatening type. And then finally, there's doorway and structural issues. So that includes the heart valve problems. Aortic stenosis would be like an aortic valve that can't open and close properly. Regurgitation in medical speak is leaky, so a mitral valve leakiness. ASD and PFO are shorthand terms, but for basically holes in the heart. And then a weakened heart muscle, which is congestive heart failure, and we kind of call cardiomyopathy, which is fancy Latin speak for basically heart muscle weakness. Atherosclerosis is kind of the backbone of what I'm trying to prevent or treat, depending on what phase I see people in. Basically, it's plaque buildup. And in cardiology, that's heart arteries, but it could be for any artery wall. That's called atherosclerosis. It's mostly from cholesterol plaque buildup. It is more preventable than other types of heart disease. In other words, there are certain things we could do to try to prevent it from happening. It includes 4 major broad strokes. One is coronary heart disease, which is heart artery problems, which includes heart attack. Angina or angina, depending how you want to pronounce it, is heart-related pain due to heart artery blockages or squeezing. And then heart failure can be considered a part of coronary artery disease, although not all heart failure is related. Cerebrovascular disease is basically your stroke category. So that's strokes and TIAs. I help to try to prevent that, but obviously neurologists deal with strokes more often in the inpatient setting. Peripheral arterial disease or artery disease includes plaque disease in the legs causing pain. It could also be a couple other places like the carotid arteries. And then aortic atherosclerosis is an abdominal aortic aneurysm, which happens in a certain subset of patients. So a lot of what I focus in on is the coronary heart disease, which is the cardiac arteries or coronary arteries. Counts for about 1/3 to 1/2 of all cardiovascular disease in general. So of those 4 broad categories, it's almost half of that. So lifetime risk is about half in males and females by the time you hit age 40. But even if you make it to age 70 without having any sort of heart artery blockages, you still have a 35% percent chance in males and about a 25% in females of developing coronary artery disease. So the lifetime risk is rather high, which is why there's a lot of cardiologists who exist. This is a little bit of an older slide, but basically it's showing us the death rates for coronary artery disease in the US over a couple decades. And in general, we get better over time in any age group. And in any ethnic group for that matter. Obviously, there's some disparities in healthcare in terms of what race you are, but overall, all the trends go down. This slide is kind of a similar idea, but it goes all the way back to 1900. As the decades progressed in the 20th century, more and more people began to die from cardiovascular disease. It's kind of a combination thing. A, there's more people as time goes on, and B, we started living longer. People tended to die earlier in the 1900s from things other than heart disease, things like pneumonia and infectious disease and tuberculosis. They got them before heart attacks did. But as we got better at treating those things, basically heart disease started to go up. This arrow right here is basically where stents came into play as being a major turning point. You could kind of see a sharp decrease after that of cardiovascular disease in general. So still talking about coronary artery disease, even though all the curves are still going down, complications are still high and costly to treat. America is very good at diagnosing and treating heart attacks. We kind of fall behind the 8 ball sometimes in terms of prevention. It's all well and good to treat it when it happens, but it's a lot more important and cost saving actually to prevent it in the first place. Heart disease is still the leading cause of death in most developed countries and still increasing rapidly in what we call developing countries. Definitely over 1 million Americans die every year from heart disease. But in the past 20 years, death from heart attacks in general have gone down. Progress, this slide's a little busy, so I'm not going to really talk too much about it because it ultimately doesn't really matter much. But this was done for our American Heart Association talk, so I have a couple key points from them. But we've seen a significant drop in basically 2007 and 2014. And then going deeper, even with coronary artery disease, about 25%, and stroke, steepest declines in populations we consider to be underserved. But unfortunately, beginning around 2015, things started plateauing and getting a little bit worse. And we think that it's because Americans are more obese and a lot more people have diabetes. And that factors into people living with heart disease and dying from heart disease. And of course, we see that in certain areas of the country that are more underserved. So yeah, I didn't want to spend too much time on this, but the broad strokes is that we're doing good. We kind of hit more of a plateau in the last 5 or so years. Likely a combination of a couple factors, but obesity and diabetes are 2 among them that are higher. So I'm gonna switch gears a little bit, and most people more interested in this sort of slide, signs and symptoms of heart disease. Am I gonna have something, or if I'm having symptoms, is it something to be concerned about? And these are things I see people for all day long. So the most common things, and these are things I ask all my patients, but common things would be chest pain, chest discomfort, chest pressure, particularly when someone exerts themselves. Rest pain is sometimes heart disease, but it's more likely that if it's exertional, it's more in my arena. Shortness of breath or difficulty breathing, difficulty lying flat at night, swelling in the legs, dizziness, lightheadedness, although I would say that dizziness, like the room spinning, is less likely heart, while lightheadedness could be heart. Fainting, which I get a lot of consults about, and then a racing heart, feeling like palpitations. Women and people with blood sugar issues or diabetes can present atypically, such as nausea. I say atypically, so when people think of heart attacks, they think of an old man clutching their chest and kind of keeling over. That's because a lot of the studies have been done on kind of old white guys. So that's how they typically present. But females and diabetics actually don't need to present with chest pain necessarily. Sometimes they present with other symptoms. So it's kind of important to recognize that. Going back to my house analogy, the plumbing symptoms, so those are heart artery blockage situations, include chest pain, chest discomfort, difficulty breathing. Electrical or arrhythmia issues include feeling your heart race or palpitations, fainting, lightheadedness. And then the doorway, like the valve issues, include shortness of breath and fainting. I will say that heart disease does overlap with a lot of other problems. So just because you have one or several of these issues does not mean you necessarily have heart disease. For example, shortness of breath and feeling lightheaded could be something else entirely, like people who are anemic feel both those symptoms. So that's not heart in that case. So it's important to bring it up with your doctor. And then if he or she thinks that maybe heart, possibly see someone like me. Risk factors, these are the most classic risk factors that we have. This slide was picked up from something older, so we've changed the blood pressure guidelines since then. But basically being a male above the age of 45 or a female above the age of 55. The distinction there is that females go through menopause. The estrogen effects before menopause seem to protect females, but once they go through menopause, they catch up to males right after that. A family history of premature heart disease, which means definitely someone who had a heart attack or sudden death, age 55 in a male first degree relative, which is like mother, father, brother, sister, or before age 65 in a female. Current cigarette smoking, although prior smoking history has something to do with it as well, but current cigarette smoking is especially bad. Hypertension means high blood pressure. So nowadays, above 130 over 80, used to be 140 over 90. HDL cholesterol, we're gonna get into cholesterol in a minute, but HDL is the good cholesterol. So if that's low, that's actually a risk factor. And then what we call negative risk factors would be heart protective things. So HDL above 60 would be a protective thing. Again, I'm gonna go into cholesterol in a minute or in a couple minutes. There are other risk factors that can equate to actually having a history of heart disease. So for example, if you have a blockage in a carotid artery, that gives you a heart risk factor independently of having a heart history. Diabetes is the same deal. Having a high blood sugar, even without diabetes, has its own risk factors. And then chronic kidney disease, so people on dialysis, for example. All these things can be thought of as fairly significant heart risk factors, and it changes actually how we treat these patients in terms of cholesterol control and blood pressure control. All these slides that I have, this is probably the most important one. And when I'm doing a talk, I tell people this is the one, if you're going to write something down, or write something down, because these are the things that we can actually change in our lives. And these are all risk factors for heart disease. So smoking's at the top of the list because it's the biggest one. It's the biggest modifiable risk factor we have for reducing risk of heart disease. High cholesterol, because we could do something about that for most patients. High blood pressure, diabetes. Abdominal obesity means kind of a gut, basically. So, having a big belly. Psychosocial factors, which we'll get into in a little bit. Dairy intake of fruits and vegetables, which is over-encompassing theme of your diet in general. Regular alcohol use, and then regular physical activity. I'm going to go into most of these in a moment. So cholesterol, said I'll come to it, and here we are. There's a total cholesterol, which we look at, but it's broken up into three main constituents, which is LDL, HDL, and triglycerides. A lot of the studies done have been looked at the LDL, which is quote unquote the bad cholesterol, as a marker for potential of heart disease. But sometimes we use total cholesterol for tracking purposes. This is a slide from one of the first statin trials. Showing increased cholesterol means increased heart risk, and a coronary risk ratio on the left means you're X amount of times more likely to die of a heart issue. So for example, if your cholesterol is above 300, you have over a 4 times chance of dying. Meanwhile, if your total cholesterol is about 150, it's about 1 to 1. So you really don't have a significant risk at that point. Different types of cholesterol medicines exist. Statins are kind of our tried and true. They've been around for 30, 40 years, most well studied and the highest risk reduction. Triglyceride lowering medications, like the bile sequestering ones, those are called fibrates. Zetia, which works in the intestines, niacin, and there's a newer one called Visipa, which works as well. This is just looking at statin, one of the first statin drugs. The blue is a placebo and the red is the medicine. And basically the left is looking at deaths and on the top is basically having a heart attack with or without dying. And both those lines are, both the red lines, excuse me, are much lower than the blue lines, kind of indicating that over time, you get a good risk reduction in having a heart attack and then dying from one as well. Examples of type of statins, the ones I use the most are the first and last one, Lipitor and Crestor. Lipitor is out a little bit longer than Crestor, but both are very potent statin drugs. Pravachol or Pravastatin or Zocor or Simvastatin are more of the intermediate ones. I use them on occasion, but most people nowadays get placed on either Lipitor or Crestor if they're going to go on a statin. Cholesterol goals, for many years, the goals were for the bad cholesterol and focusing on that only. So they were shooting for a goal of less than 70 if you had a heart attack, for example, or a heart stent or heart bypass surgery for that matter. If you have a couple risk factors, things like diabetes, things like high blood pressure, cholesterol, smoking, you wanted 100 or less, and then less than 160 for someone no risk factors. And that was the old way of thinking about it. Guidelines changed a little bit in 2014, so that no matter what your cholesterol was before you started with having a heart attack, you want that LDL in half of what you originally started with. Additionally, it suggested you use high dose, high amount of milligrams, no matter what statin you use. This shows you the convoluted newest recommendations. Obviously, I don't want you to memorize this at all, but basically, anyone who has a clinical manifestation of a heart artery blockage, or at least have risk factors, we think about them very differently. Nowadays, for primary prevention, which is your 40s, 50s, 60s, 70s, and you want to try to prevent a heart attack, if your LDL is less than 160, you could at least do some risk stratification tools or talking about stuff. If your LDL is really high, we tend to put them on a cholesterol medicine. The cholesterol is really low, we tend not to. In the middle, sometimes we do things like coronary artery calcification scores or stress tests, or I use a carotid artery every once in a while. But there's actually an online risk calculator that we use on occasion, and then that could help us. Secondary prevention, which is all the left-sided stuff, basically, if you had a heart attack, you're going to be on a cholesterol medicine of some sort. So, the question is it going to be a really high dose or something a little bit lower dose? So again, you don't have to memorize this. This is stuff I have to go through every day and thinking about my patients, about how good or bad their cholesterol is. So the other reason why I put this slide up is to kind of remind people that not everyone is the same. So we can't blanket term everyone and say everyone's cholesterol has to be a certain number, because everyone's a little bit different. So blood pressure, something I deal with every single day as well. An important risk factor for heart disease, including stroke. The classic was less than 140 systolic or top number, but we changed it to now less than 130 over 80. That was a couple of years ago now. That is less strict for people who are older, however. So once you get to 80, 85, 90, basically you don't benefit as much from having strict blood pressure control, and additionally are more likely to make you pass out. So I generally don't get as strict, but this little graphic kind of shows what we consider stage 1, stage 2, and something that's serious. When patients call me saying, my blood pressure is too high, I'm worried. If they tell me that their blood pressure, for example, is 160 over 90, I don't think they're about to have a stroke. Of course, I want it to be lowered, but we don't have to do anything emergently. On the other hand, if it's above 180, 185, 190 over 120, I get a little more nervous. Nervous is a strong word. I get a little more concerned. and then we talk about what to do. Sometimes I send people to the hospital, other times we could do it with oral medicines. But you know, that's where I get more concerned. Medications for lowering blood pressures are many. I mean, there's at least 6 or 7 different categories of blood pressure medicines, all of which have like 10, 20 drugs. So every single medicine has their own role. And you know, usually get people to what they need in terms of blood pressure control just by trial and error. Smoking, basically smoking is bad. That's a short answer, but it doesn't matter what type of smoking you do, whether it's cigarettes, pipes, electronic cigarettes, vaping, mouth tobacco even, it has been correlated with increased risk of heart-related diseases, high blood pressure, numerous types of cancer, strokes. Quitting tobacco is basically the #1 thing you can do to help yourself if you smoke tobacco. So that I don't need to beat over everyone's head. Diet. So I'm going to talk a little bit about diet. I will preface this by saying that notoriously doctors are crummier than other professions out there about talking about diet. You know, we were taught how to discuss it, but like nutritionists and dietitians have the time to sit down and go over everything. I could give broad strokes, which is what we're going to do, and that's what I do for my patients. But I always preface it by saying that. So the 3 kind of primary macronutrients that we have include carbohydrates, proteins, and fats. Some people consider fiber to be as well, which is important by itself. Basically, you should have about 50% give or take from carbohydrates, about 20-25% from protein, 20-25% from fat. These are not exact numbers, so you don't have to write these down. But you really shouldn't have all your diet consists of fat, obviously, and not all your diet of carbohydrates. You need to have a little bit of balance. Talking about carbohydrates specifically, foods with high glycemic index should be substituted with low. We started coining this term for diabetics, but it also applies to cholesterol control and heart issues. So for example, pizza, white bread, white rice, more or less anything that's white in color have a high glycemic index, while whole grains, fruits, veggies are considered low. If in doubt, kind of what I'm insinuating, if it's white in color, it generally has a high glycemic index. Fiber is important. Most whole grains, fruits, and vegetables have high fiber in it. It does reduce the risk of heart disease, diabetes, certain types of cancer like colon cancer, and overall death, actually. So fiber, I kind of threw into carbohydrates. Proteins should be variety. Humans, by definition, are omnivores, so we have evolved to eat some meat. Unfortunately, we've kind of gone the opposite way. A lot of people, I might have a slide on this, but a lot of people ask me, should I go vegetarian? And it's really a personal choice. I'm not an advocate of doing purely one thing, because vegetarians, although they have a higher intake of fruits and vegetables, obviously, they're also missing out on some other nutrients that you can only get from meat. But things in moderation are okay. So we always focus in on fish, lean meat like chicken or turkey, eggs, beans, peas, soy products, unsalted nuts and seeds. Notice I didn't really say red meat. Really, a lot of red meats have more trans and saturated fats in it. So any protein benefit you get from them are kind of stripped out by the amount of fat it has in it. That's not to say you can never have red meat again. It's just, again, some Americans have gone the opposite way and have, steak followed by a hamburger, followed by some other ground meat thing, multiple days a week. So that's obviously not the way to go. I usually tell people red meat once or twice a month is probably not going to be the worst thing in the world. Oh, and then pork, people ask me about it. Well, pork is generally okay, like pork tenderloin, for example. Bacon, obviously, more fatty than anything else. So I try to tell people to avoid that. Fat, so actually there's different types of fats, and the type of fat's probably more important than the amount you have. For example, saturated trans fats actively contribute to plaque deposits, while the monosaturated and polyunsaturated fats are protective. So saturated fats includes things like meats, cheeses, ice cream, which are the bad ones. The monounsaturated and polyunsaturated fats are the good type, like fish, which is like the omega-3s you hear about, olive oil, and then nuts. Trans fats, we don't see much nowadays because, especially in New York, they've banned most of them, but margarines in the past, some vegetable fats and many fast food products had it. Things that are fried, for example. Like I said, omega-3 fatty acids and fish oil, some evidence that it reduces risk of cardiovascular disease as well, which is the focus on some of medicines that we have. In fact, there's one called Lovaza, which is omega-3s, kind of mega doses, and Visipa, which is kind of a purified fish oil. They think the mechanism of action for that is working within the liver to stop the production of triglycerides, and also is kind of like an free radical, or not really free radical, but an antioxidant more so. It kind of scavenges up the bad fats. People are very excited about Visipa in conjunction with statin medicines about reducing risk of heart disease. That's been for the past 2 years or so. They've been very excited. I haven't heard of anything bad yet. No one growing gills or anything else serious like that. So I use it for some of my patients. Micronutrients. So the thing that I focus the most in on amongst that would be salt, sodium. So high salt is associated with high blood pressure, basically, and therefore heart disease. Recommended sodium is about 2.3 grams of sodium, or 6 grams of sodium chloride, which is about a teaspoon or so of like salt that you get from your house. It's not a lot, actually. And if you look at labels of things, salt is in everything, especially in packaged foods, especially in things that are frozen. So what I usually tell people to do is take a look at what they're eating. Everything has nutritional labels on it nowadays. Not everyone, some people can eat as much salt as they want and their blood pressure is fine, but most people, the more salt you have, the higher the blood pressure. Some people even get leg swelling as a result. So types of fruits and veggies. People should be having 5 or more servings of fruits and or vegetables, mainly because they're an important source of fiber, like I mentioned, but they also have a lot of vitamins, minerals, and in their own ways decrease their risk of heart disease, cancer, and overall death. Alcohol. This is not, I'll have you look at the last line. I'm not telling people to drink. However, moderate alcohol use, and that is less than 1 drink per day for women, 1 drink or less, I should say, and then 2 drinks or less for men, can actually lower the risk of heart disease in the form of raising the good cholesterol. Anything more than that, generally speaking, you're increasing your blood pressure and you're actually having more of a risk of heart disease. Also, if you're not drinking already, I'm not suggesting to go out and get, your favorite wine and have, a couple glasses of wine every day. But if you already are drinking, first of all, make sure you're not drinking more than what is recommended here. But if you are already, it's not the worst thing in the world. However, there are certain heart conditions that you shouldn't be drinking with, such as certain heart arrhythmias. So definitely talk to your doctor about your drinking habits if it's a question. I'm not going to get too much into types of diets. There's a lot of fad diets out there that, like the Atkins diet, the keto diet, intermittent fasting, and things like that, that kind of come and go. There's only 2 here that really have been shown to reduce risk of heart disease: the Mediterranean diet, which is high in fish, nuts, olive oil, and vegetables, and then the DASH diet, which is also rich in fruits and vegetables, whole grains, low fat dairy foods, and limit your sugar, red meat, and fats. Basically anything you think about, most people think about for having a heart healthy diet. If you look online, they actually have like cookbooks of Mediterranean diet. So that's always a good resource that I have. I mentioned vegetarian and low fat in general, kind of self-explanatory. Exercise, I get asked this a lot. Huge amount of benefits for exercise in terms of overall mortality, heart disease, blood sugar issues or diabetes, certain cancers, obesity, osteoporosis, so a thinning a thinning of bones, and dementia. Actually, there's been an association of decreased physical activity and increased risk of dementia. Basically, this is not a one size fits all. Obviously, everyone has different needs and different restrictions. You know, some people have issues with their knees or hips that limits them. But generally, a weekly goal of 150 minutes of moderate intensity aerobic activity or 75 minutes of something really vigorous. For example, like walking around, usually it's a brisk walk, not just a saunter, like a couple miles an hour, doing yard work. Once you start to get up to like playing tennis or bicycling for distance or for speed, you're getting into vigorous intensity. So if you break down 150 minutes over the week, basically it's a half an hour, 5 times a week. So most people could fit that in. 150 minutes seems daunting, but most people could fit in a half an hour of doing something that raises the heart rate. People also ask me, should I hit a target heart rate, or what should I be looking for? Try to get to a point of just under breathlessness, fatigue, or like a massive sweat. Should be sweating a little bit perhaps, but not a massive sweat. Going up to a certain heart rate has shown no real significant benefit. I often will tell people for their age what heart rate they should get up to, and it's based on their heart rate, because we use stress tests to quote unquote stress someone's heart. So usually I don't want them going above a certain amount of heart rate. But generally speaking, if you're over the age of 80, for example, you shouldn't be getting your heart rate up to the 150s with exercise. Should be closer to the 130s probably. I did a talk like this around the holidays. So always like kind of throwing this in there really quick. We're still in winter time, so there's still some of this applies. There is some association between having heart attacks or heart disease around the holidays, and particularly heart attacks are more common. The reasons being cold weather itself actually may cause an independent risk factor for heart disease, and heavy exertion. The classic is shoveling snow. So that's cold exposure and heavy exertion. That's why we tell people to avoid shoveling their old snow if they have high risk for heart disease or have a history of heart disease. Being stressed out around the holidays is very common. So heart issues can happen. Being sedentary, people are indoors a lot more. Illnesses such as the flu, and now more recently COVID, can increase risk of heart attack, and then overindulgence of food and alcohol. So around the holidays, I tend to see more people in the hospital with heart failure because a lot more people are eating holiday type foods, which tend to be higher in salt, and then everything else that I just mentioned. I'll explain an arrhythmia issue specifically in the next slide. But not only is it's weird, not only the heart issue is more common, they're more likely to be fatal. The reason being, I think a lot of people around the holidays tend to ignore symptoms because they don't want to inconvenience themselves or their family, or they think they're from like indigestion because, oh man, I had too much to eat the night before. But by knowing triggers and signs and symptoms, you could try to parse out what's serious or what isn't, or at least have a low threshold for asking your doctor. And of course, moderation is also advisable. Something called a holiday heart syndrome, which is basically just atrial fibrillation, but it was kind of coined in the late 80s because they noticed around Thanksgiving, Christmas, New Year's, people were coming in with these arrhythmia things, feeling the heart race, shortness of breath, swelling in the legs, and they were typically diagnosed with this atrial fibrillation. Atrial fibrillation is a very common arrhythmia, like I mentioned before. It is the most common arrhythmia. The arrhythmia itself can be harmful to the heart, although typically people don't pass away from it. The way that atrial fibrillation affects the heart is by making it go too fast. And if the heart's going too fast, it's not being an effective pumping mechanism. People can therefore get fluid retention in their lungs or in their legs, and the lungs causes shortness of breath, and the legs causes swelling. And people typically don't feel right when they're in atrial fibrillation. They'll get more short of breath independent of the amount of fluid they have in their lungs, or they might have chest pain or dizziness or lightheadedness. They could even faint. The actual main risk factor for atrial fibrillation outside of those issues is stroke, because the arrhythmia comes from the top chambers. The top chambers are kind of quivering and not pumping blood effectively, and blood that sits around can clot, and clots will go to the brain as a stroke. So if you have enough risk factors, you may have a high enough risk of stroke that physicians may feel more comfortable than being on blood thinners. So that's the main discussion with atrial fibrillation, is being on a blood thinner or not. That's kind of the basics of atrial fibrillation. Talking more about this, generally people have increased amounts of food, particularly salty ones. Binge drinking alcohol is also more common around the holidays. Alcohol is an independent risk factor for this atrial fibrillation. And then, basically you don't want to be doing this if you have a history of heart disease anyway. So we generally recommend, watch how much salt you're eating, limiting alcohol intake. You kind of see a recurring theme from my end about limiting salt and limiting alcohol. I added this slide this year, since this is all anyone can think about. I have 2 slides on it. So COVID-19 and the heart. So to start with, obviously, most of this is still investigational. COVID's been around for about a year in this country, a little more than that in certain portions of the world. So we're still learning about it. There is a link between COVID-19 and manifestations of certain heart diseases, but the causes we haven't really been able to establish. For example, is it really like the virus causing a direct heart issue, or is the virus causing something else and the heart's reacting to it? So for example, the virus itself can cause a direct heart muscle weakness by directly infecting the heart itself or in having an inflammatory response. It could cause something called a hypoxic injury, which is low oxygen. So if it affects the lungs and you don't have enough oxygen, the heart feels that. And to a large degree, if that happens, the heart can actually get weakened. There is something called Takotsubo cardiomyopathy, which is a stress-induced cardiomyopathy, which is really just meaning the stress of being sick itself can cause the heart muscle to be weakened. There is some evidence that COVID can directly cause a heart attack by causing pre-existing plaque deposits in the heart arteries to rupture and clot off. If the lungs are failing, that can actually affect the chambers of the heart that pump blood to the lungs, and that could actually strain and cause it to fail. And then the thing that we get worried about the most, as the body's trying to fight against the virus, it goes overboard and it inflames everything in the body, irrespective if it's your own tissue or the virus itself. So that's kind of an overwhelming inflammation due to the virus. So heart issues can present in a variety of ways. For example, someone could have no symptoms at all, but they found some people within blood tests or imaging tests like MRI, they look to have heart damage. So they don't know it, but they did. And then other people who actually have the classic symptoms of heart disease, including the chest pain, shortness of breath, et cetera, we've discussed. I saw a couple studies suggesting that greater than 20% of patients who had COVID had MRI findings of heart inflammation or injury, but a lot of these people felt fine. So they really don't know if that means anything. Could just be like a red herring, for example. But we're looking into that because, people seem to be doing fine. Cardiac manifestations are lower than other like lung problems of COVID, but we don't know what it's going to do, 10, 20 years from now. So, like rheumatic heart disease was much more common in the early 20th century. As we treated things, rheumatic heart disease became better, but basically rheumatic heart disease starts with an infection as a child, then later in life they have heart valve problems. So we don't know if COVID's going to be something like that. Complications of having COVID in terms of heart risk could be absolutely nothing, which is a vast majority of people, but some people do get heart failure, they get shock, heart arrhythmias, and death from any of the above. Treatment's really no different than any other heart problem. You just have the complications of other organ systems not doing well, such as the lungs. And then obviously this is the input for vaccinations. People having pre-existing heart disease tend to have more severe outcomes in terms of having COVID if you get it. So this does seem to be true. And that's as simple as high blood pressure, but the more heart issues you have, the more chances you have of not doing well if you get COVID, which is why we've been so gung-ho about people getting vaccinated nowadays. So this is kind of a conclusion wrap-up section, then I'll answer some questions. So in general, heart disease has a large impact on our society. Certain risk factors can be modified. That was one slide I mentioned, and I'll reiterate some of them. That includes diet, exercising, stopping smoking, getting regular checkups to your regular doctors to look at your blood pressure, cholesterol, and blood sugar. Symptoms of heart disease are varied, and most, if not all, are treatable, which is why I like my field so much, because I could do something about it. Advances in medicines are always happening. So, for example, there's a procedure called a TAVR, TAVR, where we could replace an aortic valve by going through an artery in the leg. 20 years ago, the only way that we could replace a heart valve, aortic-wise, would be open heart surgery. And nowadays, this is the preferred method, not opening up someone's chest. The difference is, with going through an artery in the leg, you can go home the next day. With open heart surgery, you're in the hospital 5 to 7 days, and then 3 months of recuperating from that. And the heart valves that they use seem to be pretty durable as well. So it's a very exciting time. And then there's always new types of pacemakers, such as ones that could detect signs of heart failure. Something we do in our office, we can install a heart monitor underneath the skin that's the size of a toothpick, and monitors for heart arrhythmias. That's its primary function. But they just made a second iteration of it that has all these sensors on it. They're not online yet, but one day they could actually detect things like blood pressure changes, blood sugar changes, can detect if someone's going into heart failure. So it's eventually going to be kind of like you get installed a chip and it can tell everything about you. But we're not quite there yet. And then if always in doubt, I mean, always talk to your physician about anything that you have questions about, especially if you're concerned for a heart issue. References we don't care as much about. So that's my general talk. I know there were a bunch of questions. I don't know if you want to ask me the questions. I looked at them beforehand, but I don't have them up in front of me right now.
So if anybody wants to chat in the question, or you can raise your hand and I can allow you to speak. Any questions?
Well, I know there's one question about Visipo. Hopefully I sort of answered that one. That one, like I mentioned, has more to do with triglycerides, but it can help the LDL, which is a bad cholesterol, go down. And we think its mechanism of action is within the liver in terms of excreting out or chewing through these bad cholesterols. It's also acting as an agent, like a antioxidant, and kind of scavenging up the harmful cholesterol. So that's why people got so excited about it. Also, it didn't seem to have many side effects. So that one I knew was asked. I think there was one question about how does AFib affect the heart? And I know I talked a little bit about that. Hopefully that answered that question. What else did I remember seeing? Those are the main ones. What else did I see? Let's see something. Actually, I think I can access on my phone without kind of going into, I don't want people knowing their names and what they, okay, so here I have a list of the questions, so I'm just going to answer them myself then. Can you address heart healthy foods and ones to avoid? I think I did that. Can stents get clogged? Yes, heart stents can get clogged. The first stents that we had back in the late 90s, early 2000s, it was much more common. The ones that we use nowadays, it is incredibly rare. That is so long as you take the medicines that were prescribed. So if someone gets a heart stent's like a metal scaffold that alleviates a blockage in a heart artery. It's a metal object, so it's a foreign object. So the body sometimes tries to clot around it or try to aggressively put down tissue to get rid of it. The way we get around that, we give someone aspirin and another medicine, like something called Plavix, to thin the blood, but more so to stop the body from being overzealous and healing around the stent. So as opposed to healing all in a week, it kind of makes it heal around it for about a year or so. So the chances of a stent clogging nowadays are very, very little. It does happen on occasion, though. Most of the issues that I see are because someone forgot to take their blood thinners, but there are some people who it happens to anyway. That's just bad luck. Like I said, the stents nowadays are much better than they used to be. This one's AFib affect my heart, I mentioned. Latest research on the VASIPA, I said that. Best kind of exercise routine to follow. I sort of mentioned that. I usually tell people pick something you like. Some people like swimming. They have access to a pool. That's a great way to exercise because if you have knee pain or joint pain, there's no impact. Bicycling on a stationary bike, these Pelotons, which are very famous now, tend to help people with knee issues as well. Pickleball, people tend to enjoy a lot. It's not as physical, obviously, as full professional tennis, but pickleball is a great way to get some exercise in. So I usually tell people pick something. Like I said, it's about a half an hour of doing something like that. If nothing else, just getting up and walking around outside for a couple miles when you can beats sitting in front of the TV doing nothing. Link or relationship between COPD and heart disease? Yes and no, and I'm being a little coy about it. COPD is a lung disease typically caused by smoking. Smoking is an independent risk factor for heart disease itself, so that's the commonality. The way that COPD can specifically affect the heart, there's two main ways. COPD can occasionally cause atrial fibrillation. Lung issues occasionally cause atrial fibrillation in general, such as pneumonias and lung infections. They could actually do that. So atrial fibrillation would be one way. And then the other way would be if the COPD is so bad, it could actually backtrack pressure on the chamber of the heart that pumps blood to the lungs. So basically the heart has four main chambers, two bottom ones, which pump blood throughout most of the body. The bottom left chamber is the one that pumps blood to everywhere in the body minus the lungs. The right side of the heart pumps blood to the lungs. So if the lungs have issues, the right side of the heart can't accommodate that, so occasionally it begins to fail. That manifests by having swelling in the legs mainly. Shortness of breath as well, mostly that's from the lung disease, but swelling of the legs. So those are the main relationships between COPD and heart disease. What can a patient do to stop the progress of heart wall stiffening? So the human condition, unfortunately, over time is to have the heart muscle stiffen over time. And that also goes true for heart arteries and any artery in the body. It's just a natural progress of aging. Heart muscle stiffening can occasionally cause fluid retention. So when I do echocardiograms and I read them, I can actually see indirect evidence of that in most patients. And most of my patients above the age of 70 have a mild stiffening. So there's no real way to prevent that. The way to prevent it from getting worse than mild, because once you get worse than mild, it becomes so stiff that it can't accommodate any sort of pressure change, and then they could get fluid retention, blood pressure control. That's the most important thing. Salt content had something to do with that, but if most of the time, if someone's going to get a very stiffened heart muscle, whether by genetics or otherwise, controlling the blood pressure is probably the most important thing. Leaky valves, I sort of mentioned in my house correlation. Leaky heart valves can happen to anyone. It can happen from a congenital problem or just over time. We keep track of leaky heart valves with echocardiograms. Generally speaking, if it's a mild or moderate leakage, it's not going to cause symptoms of any heart valve. If it's severely leaky, it really depends on how the person feels. Most often, if someone has a leaky heart valve, whether it's the aortic or mitral valves, they typically feel short of breath if it's going to affect them at all. So if that happens, the discussion then goes to, do we need to fix that valve? And that's usually through a surgical or procedural type of thing. There is no magic fix in terms of medicines for it. So it's usually a mechanical fix for it. Related to that, someone asked about heart murmurs generally getting worse as one ages. Heart murmurs are noises that physicians can hear, or nurses for that matter, can hear with their stethoscope. So a heart murmur would be a noise, kind of a churning going on within the heart. Now, heart murmurs need not be terrible or life-threatening. In fact, some people have benign murmurs. Other murmurs are affiliated with leaky heart valves, which I just mentioned, and other heart murmurs are affiliated with a stiffened heart valve. The way we can tell the difference, besides listening, sometimes we could hear patterns of things, but really a heart ultrasound called an echocardiogram is the way we diagnose it. In terms of heart murmurs getting worse as one ages, it depends on what the murmur is caused by. Patients who have aortic valve stiffening, called aortic stenosis, that one almost always gets worse as people age. The question is how fast. It's usually over years to decades. But that can get worse as people age. The other murmurs, not necessarily. And childhood benign murmurs typically disappear by the time they get to adults. So that's that one. And then, does blood pressure medicine affect balance? It can. Blood pressure medicines typically cause more lightheadedness and feeling off balance rather than true being off balance. People who feel off balance typically have either a medication side effect or some sort of neurological problem or a leg weakness problem or joint problem. But definitely blood pressure medicines can factor into all that. So the best way to figure that out is get your blood pressure checked regularly. If it's too low, then that can affect your balance. And then always talk with your doctor about potential for side effects and medicines interacting with each other, which can definitely cause issues. But most blood pressure medicines won't cause someone to like just suddenly peel off to one side while they're walking or something like that. So those are the questions that were asked ahead of time. I don't know if anyone has any other questions currently.
This is Linda Sweeney. So we have a question. What is aortic fibrillation not caused by heart? And
when is atrial fibrillation not caused by heart?
yes.
So atrial fibrillation comes from the heart. So it's always within the heart itself. Other things that can indirectly cause, so atrial fibrillation can happen in of itself just by virtue of genetics for some people, although most people are falling in the category of getting older. So getting older increases the risk of atrial fibrillation. Other things that go into risks of it would be high blood pressure, diabetes, sleep apnea is becoming more and more recognized as a risk factor. And then other things like too much alcohol, too much caffeine, getting lack of sleep, dehydration, all these things can tip off atrial fibrillation in the right setting. So atrial fibrillation always originates in the heart. Sometimes it just originates by itself, independently of everything else, but occasionally it's triggered by something else. And those are the main conditions.
Okay, I don't have any more questions from anyone else. Thank you so much, Dr. Sorrentino. This was extremely informative, and we really thank you for your time.
No problem. I hope everyone has a safe and happy rest of their rest of COVID. Hopefully we'll be over this soon, guys. All right.
Thank you so much.
Well, no problem. Bye-bye now.